Hi, and welcome to the first webinar in the Center for Interdisciplinary Health Workforce Studies 2015 Fall Webinar Series. These webinars are focused on value-based care and the implications for the health workforce, particularly the nursing workforce. We are pleased to have all of you joining us for today's webinar. First, a few center announcements before we continue. We have completed this center's transition from Vanderbilt University to Montana State University, and we hope you will visit our website and take a look at our newly branded site. The address remains the same, which is www.healthworkforcestudies.com. Second, we have just published a very important article in Medical Care Journal forecasting the size and age distribution of the nursing workforce and comparing our projections to demand recently projected by the Health Resources and Services Agency. These are important findings that suggest that while the shortages are not as dire as previously projected, we will still face challenges to meet future needs. We have a write-up with links to the article available on our website. Please feel free to post and share this information with your networks and colleagues in newsletters, on your social media accounts, websites, etc. Lastly, we will be releasing some data on the RN employment age characteristics for the second quarter of 2015. And then over the next 6 weeks, we will release some data briefs on other professions, physician's assistants, physicians, etc. So be sure to check our website in the next few weeks for more information about this data. Now, turning to today's webinar, we intend to allow for discussion time of about 15 to 20 minutes after our speaker concludes his presentation. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many as we can. We are also recording the webinar today, and we'll have it posted to our website. We have posted all of the previous webinars to our website, so if you missed any of our previous events, you can find them there. You can also find presentation slides posted within the event calendar as presenters allow. Today we have a great presentation focusing on value-based care and implications for the nursing workforce. I would like to allow Peter Bierhaus, Center Director, to take a minute to talk about why we decided to focus on value this fall, and then let him introduce our speaker. Pete?
Hey, thanks, Christy. Well, first of all, I'm coming to you from the beautiful Big Sky country in Bozeman, Montana, and I'm broadcasting from our new home here at the College of Nursing at Montana State University. Now, I'm truly delighted that our fall webinar series is focusing on the value of healthcare and the implications for the healthcare workforce, particularly nurses. There's a lot going on in the healthcare system today, and I just want to tick off a few things that are on my mind and bring in value at that point. But when you think about what's going on with healthcare, we've got a change in our delivery systems, hopefully aimed at improving coordination, quality, efficiency, and accountability. And I'm thinking about the ACOs, medical and primary care homes, and of course, these delivery changes will affect the workforce. But it's awfully early yet to see how and what exactly is happening. Then we've got the increasing emphasis on prevention and education aimed at decreasing future inappropriate and avoidable demand, and hopefully to promote better health. Again, that switch to prevention and education will have profound impacts on the healthcare workforce. A third big shift is something we've all been witnessing, which is the expanding access to care through the variety of insurance reforms, from Medicaid expansions to the state market reforms. Of course, we'll see some increase in demand as a consequence of the insurance reforms, and that too will affect our nation's healthcare workforce. But to me, the biggest change going on now is the change in our payment system, which is aimed at stripping away volume-based utilization incentives that were based in the fee-for-service system to favor more efficient, value-driven care. To me, that is the one overall change in our system that will have the biggest impact on the healthcare workforce, and particularly for nurses. And we've already seen some of the early signals. Secretary Burwell has declared that 80% of Medicare fee-for-service payments would be tied to quality or value in 2016, and that figure would rise to 90% of payments in 2018. That's big news. Then, of course, Congress eliminated the sustainable growth rate formula that was heavily influencing physician payment reform and changed to a completely different method of paying physicians that will be based in part on quality and value and a number of other factors. So this change in our payment system is starting to ramp up, and it will have enormous impacts. And therefore, Christy and I thought it would be great if we spent our fall webinar series focusing in on what value is. I mean, what is value? What's going on? Everybody's talking about it. Let's get clear about what it is, and then ultimately we can understand how our delivery systems will change and the implications for the workforce. So I couldn't be happier to have Rich Lindrooth, who is the professor and co-director of the Health Services Research Doctoral Program at the University of Colorado School of Public Health, to get us going on this important topic. Rich's research is focused in the areas of health economics and health policy, and he has an emphasis on the economics of the hospital industry. He's also a health services researcher, and his focus it also includes the delivery of mental health services and access to care. Rich got his PhD in economics from the University of Washington and holds a BA in economics from the University of Vermont as well. So I am, again, extremely pleased that Rich is going to get us started with our webinar series. And with that, Christy, let me turn it back to you. Christy's in our Nashville broadcasting studios. Christy.
Thanks, Peter. All right, well, I have just made Richard our presenter, so he's going to take the wheel. And we will
All right, yeah, thanks Christy, and thanks Pete for the introduction. Can everybody see the slides now?
Yep, it looks
I assume
great.
They're up? Okay, good. And as Pete aptly warned you, I'm an economist, and as a result, I'll be focusing more so on the underpinnings of the definition of value and how it relates to nurses. So my perspective is one more from economics, but I'll be drawing some examples from the nursing literature, and we're going to tie in nurses in that way. So just to start out, what is value? It's a word that there's rare bipartisan support. It was included in the Affordable Care Act. In fact, 7 sections had the word value in the title, and the Representative Paul Ryan, a Republican, used the word value 8 times in his counterproposal back in 2010. So it was definitely stressed. It was almost used once per page. But the approaches towards achieving value differed in these proposals. Both agreed that value is a good thing. It's something that's desirable for society, and that there's a reason for government policies to focus individuals more on decisions, but the approach they took is quite different. So the ACA used the word value in the context of value-based purchasing. So purchasing by CMS or insurers, ways of rewarding high value or preferred outcomes. Whereas in Paul Ryan's plan, value was to be achieved through individual decisions, individual patients making choices that yield higher value to themselves. And so it created incentives such that the individuals would be in the position to weight the cost of care in the treatment decisions. So as I said before, it's generally preferred by anyone, but one thing that approaching value or thinking about value is it includes both a quality or outcomes component and a cost component. So individually, we could agree on the direction that higher quality makes everyone happier. We all prefer that. Similarly, lower cost. We prefer something costs less than the other. And so what discussions of value do is they bring both cost and quality into the equation and use that to guide decisions. And so by combining the two, the determination of whether increased quality is desirable, it really depends on how much it changes costs. And so there's this inherent trade-off that the value discussions bring into the mix. So the formal definition, if you will, in ways of making value comparisons, could just be thought of as the ratio between outcomes and costs. So better outcomes increase value, and then in the denominator, lower costs could also increase value because it's in the denominator. So this definition was put forth by Robert Porter. He's more of a management guru in the New England Journal of Medicine back in 2010. And then it was also adopted in a number of other reports and so forth, including the recent IOM report, Best Care at Lower Cost. And as the title implies, best care at lower cost is a value proposition. It's kind of grown out of cost effectiveness analysis, which is generally used to compare different drugs or treatments, and note cost is on top of cost effectiveness ratios, but otherwise it's very, very similar. And so when making comparisons, say between treatment A and treatment B, you'd prefer the one that is higher value, such that the outcome from A relative to the cost is greater than the outcome for B. And throughout this presentation, I'll be using the word treatment to, very, very generally. So it could be, an individual treatment. It could be any change, a change in a process, a change in staffing, a change in training. And I'll be referring to those changes as a treatment conceptually. So if, for example, if you added an additional nurse to a hospital inpatient unit, then the treatment A would be the outcome with that additional nurse. Cost A would be the cost with that additional nurse, whereas B would be the outcome without the additional nurse and the cost without the additional nurse. And so as long as the incremental improvement in the outcome is greater than the cost, then that would be a value-based decision that would improve the value of care delivered in that unit. Sometimes these decisions are easy, and for example, if treatment A improves outcomes and lower costs, then it's a no-brainer. It would always be the case that that would be adopted, and in such cases, it should be, you just need to educate people that this is a way to improve care and save costs. So you don't necessarily need a policy to focus on that if it's well known. I think the more interesting case, and where there's definitely a role for policy, is when the treatment A improves outcomes, but it comes at a higher cost. And that's when you have to make the trade-offs about what is the best course and what brings the most value to the treatment. One aspect of this is the perspective. So you may be familiar with business cases, and business cases tend to take the perspective of the organization. But policies, they should take the perspective of the population or society as a whole. And so when measuring value at the aggregate level, you're looking at what's good either, say, for an insurance population, say Medicare, Medicaid, or private insurance, or even broader, the healthcare system as a whole. And in doing so, you're aggregating the costs over all parties, and then also the payers. With the patient perspective, it's a bit different. So when patients are choosing value or making value-based decisions, they're focused more on their individual outcome and their individual costs. And given with insurance, patients do not pay the full cost of the treatment, they will weight the cost component of the value equation much less. This can, in a sense, skew individual patient decisions more towards quality because they don't bear the costs, and so it's just a rational way of making decisions. I guess some people could take one for the team and make a choice that's best for society, even if they don't pay the costs. But that is very unlikely, and it's unlikely they'd even know what's best for society. And then, as I mentioned before, the organizational perspective is focused on the business case, and so this is the the valuation of the outcomes from the organizational perspective, which may be reputation, it may include ethics, it may include mission, and how well an organization values the outcomes. And then the cost would be the cost to the organization. So they're not necessarily considering the out-of-pocket costs. They're thinking more, how much are we going to have to invest? How much are we going to have to pay our workforce in order to achieve this outcome? So in nursing, nurses are certainly central to most discussions about value. So the outcomes, certainly nurses have the ability to influence outcomes, either individually or through the number of nurses working on a unit, the training of nurses, the processes that are used, and so forth. All will influence outcomes. But this comes at a cost. Certainly nurses do get paid. I'm not sure if the costs are commensurate with the outcomes, but there is a cost incurred by the organizations that employ nurses. And the perspective of those costs is important. So if you have the case where, say, a hospital, it bears all the cost of an additional nurse, but the decision about whether to add the nurse depends on how they value the outcome. If there's no financial benefit to the outcome, then the argument comes down more towards reputation, mission, and ethics. But if the outcome is tied to some direct benefit to the organization, they should weight that outcome more relative to cost. So in terms of the evidence that's in the literature, there's quite a robust literature on improved quality through increases in staffing and increases in training, lower mortality, reduce adverse events, and so forth. I think you all will be more familiar with these studies than I am. And then on the cost side, the evidence is more limited. And part of the difficulty is that it does depend on perspective. On the surface, from the hospital's perspective, going back to the example of adding an additional nurse, the cost is straightforward. It's the salary and benefits of that additional nurse. However, when you go to the patient perspective, patients aren't tipping nurses at the end of the day or when they're discharged. There's really no direct payment that goes from patients to nurses. And similarly with insurers, there's no incremental payment by insurers if there are more nurses. I know my colleague John Welton here at University of Colorado has advocated for a nurse-based payment in order to create the direct incentive to add more nurses. And then from the societal perspective, again, that's just adding up all the costs all together. So that would include the cost to the hospital and so forth. So, costs, they're easy to understand, they're easy to measure, you can count them, invest them, spend dollars. And I think historically a lot of the focus on costs is due to the fact it is easy to measure. Outcomes, it's more difficult. It's more difficult to quantify a relatively good outcome versus an excellent outcome. And that presents a challenge. And one way the value equation gets around this is by focusing it on comparisons. And so if you are making comparisons, you can get around this measurement problem as long as you measure the outcomes the same way. So for example, with readmissions, your outcome could be the percent of discharges that do not result in a readmission. So I say do not result, so that the higher the percentage, the better the outcome. And so if you compared two different processes that are targeting readmissions, then you could just measure the cost with and without one of the processes and then the outcomes. And so you can make this apples comparison and choose the ones that yields the highest value. So I'm going to go quickly through a few examples from the literature. And I should say, generally, the literature that looks at both outcomes and costs is relatively sparse. There's an excellent literature, as I said before, that's focused solely on outcomes, but the costs of those interventions are not regularly reported. It'd be great if they were, then I could actually add many more slides on the value equation. But this is a paper I was a co-author on, along with Olga Yakashiva, who will be presenting in the next webinar, and we focused on 80% BSN staffing. So we had a unique data set that we were able to measure in a single hospital what nurses treated the patient during the course of the patient's stay. And we also knew the training of those nurses. So for each patient stay, we were able to measure the dose of nursing and what percent of those nurses had a BSN. And so we chose the 80% BSN staffing level because it's consistent with the IOM recommendations or goals to have 80% of the nursing workforce with the Bachelor of Science in Nursing. And what we found is that patients that had more contacts with BSN nurses also experienced reduced readmissions, mortality, and length of stay. And so by varying, say, for a given patient, it may go from 30% BSN just by chance, based on who was scheduled, who was taking vacation at that time, to another situation where it was 80% BSN. So we used that variation to estimate the impact. And then we simulated at this hospital how much would it cost to have a nursing staff that was 80%. And based on the incremental wages of a BSN versus a non-BSN, it would cost the hospital $1.8 million to reach the 80% BSN staffing level. However, that's just focused on the cost of the organization. When we bring it to the societal perspective, each readmission has a cost to society. You have to pay for that treatment. And the effect size of the reduced readmissions is relatively large, and they're also very expensive. So overall, from society's perspective, there was $5.6 million in savings. So the hospital perspective, like I said before, it depends on who's paying for readmissions. If the hospital is not responsible, or even if the hospital gets paid for readmissions, then they would just focus on that $1.8 million in costs, and they'd be less likely to go for the 80%. However, if the hospitals are responsible for paying for the readmission, or they're paid less, if there is a readmission, then they'll start to consider those costs and make value-based decisions. And so that's where the value-based purchasing comes into play, in that it incorporates the outcomes into the hospital's decision-making. From the patient perspective, better outcomes are priceless. They don't necessarily pay more or less, depending on whether or not they're readmitted. And there's certainly a hassle from being readmission. So you'd much more prefer not to be readmitted. And this is an example of something, as long as the hospitals are responsible for the cost of readmission, then it'd be an easy decision for them to adopt. From the perspective of society, it's a no-brainer. You have improved outcomes at less cost, so it's a cost saving. Then with nurse staffing, there's another earlier paper that builds on previous literature that looks at the quality implications of additional staff and using overtime and contract staff. And so what they found in this, the treatment was, okay, let's eliminate overtime staffing and instead hire additional nurses so that we don't have to provide these overhead hours. So on net, you have to pay more wages for the full-time nurse, but in a sense, you also don't have to pay extra overtime payments. So the effect on outcomes was reduced readmissions and ED use. As I mentioned before, these have cost implications from the societal perspective. And these overweighed the additional wages from hiring more nurses. And this would be another example of an easy value decision because it improves outcomes at less cost. And I wish that people would publish the cost, even if it's expensive, of a lot of the new innovations that we see in the literature. If not only the improvement in outcome, but also the cost was included, then I think we'd all have a easier time in understanding the value implications, and also be able to make an argument to your CFO or practice manager that such changes are worthwhile. The area of management I wanted to touch upon as well. This is a bit difficult in that the value of improved management is more diffuse. So excellent practice environment could influence a whole range of outcomes. It could reduce turnover, improve morale, increase motivation, and so forth. And we all know, being in different management environments, we know when the management is good, morale's good, quality is better, productivity is higher, and so forth. The cost of better management is also relatively difficult to measure. There's an additional initial investment. There may be training and so forth. It takes time to get buy-in from staff. And there's a lot of other elements that are difficult to quantify and link directly to outcomes. But the value proposition, it shows promise, but there's no direct evidence at this time towards value. So as I mentioned earlier, I'm an economist, and what I mean by the E word here is not economist, but it is efficiency. This comes from a colleague of mine, Mark Pauly, who calls it the E word. It seems like recently the word efficiency has very negative connotations, and it's not used as much as it was 10, 20 years ago. And so in economics, the way we think of efficiency is an efficient outcome would be the best possible quality, holding cost constant. So for a given level of expenditures, you do your best and you get the best quality. Conversely, if you hold quality constant, you have the lowest cost. So both of these would be examples of efficient outcomes. I've highlighted the quality part of these lines because often quality is ignored in discussions about efficiency. People immediately go to cost, which I think that is why it's become a word with a bad stigma attached to it. But efficiency is very, very similar to value. But conceptually, it's tied more to productivity. And so what I mean by productivity is something gets accomplished in less time and effort. So improvement in productivity, you're able to do your job better, and I'll use the word more efficiently. So are such improvements efficient? They are if quality is maintained. And so if you're seeing more patients and quality suffers, then it wouldn't necessarily be efficient. So the key point with efficiency, you're holding quality constant. Conversely, if you increase quality through increases in productivity, it's more efficient if costs are held constant or there's not a commensurate increase in costs. And so this is analogous to the definition of value. It considers both quality and outcomes and costs. And in the area of productivity is one of the crucial ways that nurses can influence value, but it's not directly rewarded in value-based purchasing and so forth. And that's where the management of your organization and of your team can improve value, can improve quality with less cost, or reduce costs, holding quality constant. So as I mentioned before, in conclusion, I think increasingly we are getting more evidence that includes both outcomes and cost. Costs tend to be ignored. I wish they weren't. I wish we had more of that. With value-based purchasing, it does infuse quality into the decision-making. So it's bringing the societal perspective into individual organizations' decisions by tying the payment to the outcomes. So it's not just counting beans through fee-for-service type reimbursement. And by doing so, it should lead management to improve, make better use of staffing, because the organizational survival depends on it. And that's where nursing can certainly play a huge role in figuring out ways to improve the outcomes, take advantage of value-based purchasing, and improve the performance of the organization. So just to conclude, value depends on both cost and quality. And I think the benefit of value-based decision or discussions on value is it does provide a framework to focus decisions on what's best for society. The purchasing infuses outcomes into the business case or the organizational perspective. And I think in a couple weeks, Olga Yakasheva's seminar will focus more on what policies are being introduced and how they can be linked to value. But thank you. That is the conclusion of my slides. I should say we've been working on a brief, and it's not quite ready for broad dissemination. I expect it will be ready in time for the next webinar. And so that'll be coming out over the next couple of weeks, and I'm happy to share it with folks. Yes, it does.
Great, thanks, Rich. We have an opportunity to take some questions. So if you would go to the questions area of the GoToMeeting toolbar and you can enter your question, we'll pose as many as we can to our presenter. Let's see. I've got one right here, so let's see if I can get this one to you. Rich, excellent presentation. Thanks for sharing. With the ability now to link nurses directly to patients, as you did in your study, how will that affect future methods examining value-based nursing care? For example, new patient-level nurse costing models, linking care of individual nurses to short-term clinical outcomes such as pain management, glycemic control, etc., from John Welton of University of Colorado Nursing.
Okay, thanks, John. I was going to say, wait, is that John Welton asking that? Yeah, and I think the new, the IT improvements are incredible. We can now measure costs at a very fine level, and to enable measurement of such trade-offs of individual processes and their incremental cost. And I think as that information becomes more widely available, that'll be one way to include costs in study and create a stronger argument for the adoption of new innovations. There's a flip side to that, in that often costs get counted too finely in a way that individuals may not have control over the costs. And so I think when you're making decisions based on this information, you have to keep in mind whether the individual nurse in this case has full control over the amount of costs, or whether random elements come into play, which can lead to variation in the amount of time and so forth. So it's definitely helpful, but I think understanding the costs, what drives them, how nurses can influence the costs are crucially important in making the results valuable.
Great. I think, Pete, you had a question for him as well, didn't you?
I did, Christy. Can you hear me?
I can.
Okay. Hey, Rich. Thank you very much. And I was really happy to see the multiple perspectives from which you were looking at value. And I've got a number of things on my mind, but I think the first one is, if you, just walk down the hall after this webinar and you ran into a nurse, a clinical nurse, who works clinically every day, what would your sort of elevator speech be? What would be the 1 or 2, maybe 3 points that you would stress to someone who comes to work taking care of patients every day?
Yeah, so in terms of value, it would be, I think, one, do your best. That how you spend your effort, how you spend your day matters. It influences outcomes. And the most immediate way to improve the value of healthcare is to put forth your effort wisely. I think from the nurse's perspective, there's influence of costs in terms of perhaps in an inpatient, for example, decisions made during the stay. They would not necessarily think about value in those decisions. I think it's good to think about what's best for the patient. But if it's found, in the organization that those decisions are not value-based, then I think it takes a discussion among all players in the unit to figure out how those decisions can be improved, and to get buy-in that a value-based, evidence-based approach would make more sense. I think one concern I'd have is if there's a vertical top-down approach to changing individual decisions that comes from management without getting the input and buy-in of staff. And I think that's an important element. And so if this nurse was concerned about changes related to value, I'd encourage them to start the conversation in order to arrive at a mutually agreeable solution on how to improve value.
Great, thank you. I've got another question here. Do you think that the inclusion of evidence-based standardized nursing languages, i.e. diagnoses, outcomes, and interventions, into electronic health records could be significant in determining and demonstrating nurses' contributions to value?
Yes, so an enthusiastic yes on that. I think it can certainly improve internal conversations on what works, what improves outcomes, and then, as John mentioned before, better tracking of the effort could fill in the cost side. And so that evidence could and should be used within organizations in making these decisions. And I think historically, cost has been overvalued. And so as we get more precise and credible information on outcomes, we could bring that into the discussion. And I think organizations, patients, and society would be better off.
Great. One more. Actually, sorry about that. I have a couple more. They're rolling in. Time and task is easy to quantify. How do you see quantifying the less tangible aspects of nursing care delivery?
Yes, that's the challenge. Actually, it is too easy just to focus on time, and I think taking a step back and assessing whether it's worth telling people to spend less time. What are the implications? What are the intangibles of doing that? There are certainly environment or workplace climate issues as well when people are just going from one thing to another, really busy all day, and the accumulation of that could lead to worse outcomes. And so when digging down to the micro level of costs, I think it's important to step back and look at the big picture and understand the implications of that. And I think the only way to do that is if everybody's involved in these discussions versus if it's just something that comes top down from management saying, we got to, cut our outpatient visits from 5 minutes to 4 minutes. I think you really need the big picture and to consider the implications of cutting it from 5 minutes to 4 minutes, and that's where the art comes in. And we don't have computers making the decisions. We have people, and so the more input, the better.
I agree. I think this one's a little bit of a clarifying question. Doesn't value, like cost, depend on perspective, i.e. patient, clinician, organization, society?
Yes, it certainly does, and I stress the cost implications as well. And part of it with value-based purchasing, it is in the hospital industry, it is holding hospitals accountable for the cost of readmissions. So the outcome in that case is the readmission, but the value-based purchasing injects that into the decision-making of the organization. Without those penalties or bonuses for better outcomes, then the organization, would include outcomes or quality, but the benefit is indirect. It's through better reputation, which could lead to better reimbursement, higher volumes in the future, and there may be mission components where, as a healthcare organization, it's your mission to provide the highest possible quality care, and then ethical implications as well. But with value-based purchasing, you're essentially making the organization accountable for the lower outcomes that would occur. From society, I think, yes, as a society we want better health outcomes for everybody, and that bears a cost to society as well. So it's really just the aggregation of everything. So I hope that answered your question.
All right, so last one I have in the queue. If anybody else has some questions, get them on over. We've got a little bit of time left. You talked about value as an important component in decision making. To what extent is information about both costs and value related to any one particular quote-unquote treatment available for decision makers at the time of making a decision, particularly consumers?
Yes, and I didn't touch on this area that is emerging with more consumer-based decision making, and there are a number of efforts throughout the country in informing individuals about value-based treatment and infusing that into their individual decision making. So, one example that I've heard recently is having your knee scoped, so having arthroscopic surgery for osteoarthritis. That's been identified as a low value procedure. I actually had that procedure 2 years ago, December, and now that I know that it's a low value procedure, would I change my mind? Would I say, no, I'll do diet and exercise, or I couldn't do exercise, but lose weight and get a few steroid shots to get on my feet again. I chose the arthroscopic surgery. I thought, my perception was that there'd be more benefit. It was presented to me that, well, we can get an MRI, but they're never conclusive. We can get the best idea of the shape of your knee through the arthroscopic surgery. And then it was presented as a diagnostic technique as much as a curative technique. And, that made sense to me, and it still makes sense to me. I wasn't paying the cost of the surgery. Now that I know it's low value, I think I'd still go for it because my physician, he was in favor of it. When I walked into the office, that's what I wanted. So in my self-diagnosis, that's what I wanted. And so I'd probably still do it as long as it was an option to me. If the physician instead agreed that it's a low value, then it may not come up in the conversation. The physician, would say, yeah, we used to do this, but now we know the cost is not really worth it, so I don't recommend it. And so if in this case, the orthopedic surgeon, if he said, yeah, I want to do this, 5 years ago I would have, but now we know it's not valuable, then I'd say, okay, I want to do it. And so the role of the physician is key. The research I'm familiar with, the most successful interventions are when an individual, practice or group or within a hospital where all the clinicians get together and figure out what's low value and what's high value. And then if they all agree, and they agree the situations where it is low value, then they could have a tremendous amount of influence on whether or not the patient gets that procedure. In the end, the clinician, is the most important advisor to the patient, and most patients will rely on that advice in making decisions. So if out-of-pocket costs are not borne by the patient, I don't see infusing the societal value perspective changing behavior very much. But if the clinicians agree on what's high value and low value and make those recommendations to patients, then I see that as having a much more dramatic input. And I think the key is having that consensus as to what works less well, such that it might not be worthwhile, and in what situations. And I think over time, we've come closer and closer to identifying low value procedures. And interestingly, I've been working on a project we're focused on the delivery of Medicaid through an accountable care organization. And this may be obvious to the audience, it's not obvious to me, but I wanted to identify very high value procedures. Those tend to be part of quality measures, so things like follow-up after medication and so forth. But I really wanted to focus on what a high value procedure is, because our papers were focused on avoiding low value. But on the flip side, if it's a capitated or global budget type arrangement, you really want to check to see whether high value procedures are being done appropriately. And there really wasn't much evidence on that. And presumably there's high value, there's a gray area, and the low value. And to date, we've been most successful in the negative side, what's low value. But I think going forward, recognizing high value and enhancing those and making sure there's sufficient access to high value treatments is really important.
Great. Got one more from the queue. Value of healthcare with respect to nurses is convoluted because nurses too often are invisible. Better data will help, but right now hospital claims don't document nurse services. When nurse services are billed incident to, they appear to be physician services. Any thoughts on what to do until complete documentation occurs?
Yes, that's a very, very good question. And I think John Walton's original question is the complete documentation side, but in reality, very few organizations have the ability to do that. So as a researcher, what we've done is really looking at the aggregate. So it would be average staffing over a month, for example. But we wouldn't be able to link individual patients and outcomes to that. And so by averaging, like the person with the question was saying, it really takes the individual out of it, and it's easy to lose sight of that individual variation. So in the meantime, what do? I think at the organizational level, it's really having the mechanisms for that input, having meetings, though I think many of us dislike meetings, but good meetings are good, to honor Yogi Berra, who passed away recently. So I think most would agree that good meetings are good if you accomplish something. And I think having those discussions as to what could improve value based on individual effort and getting agreement that that effort is important and should be rewarded, whether it be on performance reviews and promotions and so forth. It's really awarding good behavior and good effort in order to enhance it. So I hope that answered your question.
Yep, that was great. All right, Pete, you had one other question for us.
Yeah, Rich, you brought up ACOs, and I was thinking that if, say, I was the head of an ACO, and I've got all these plans to coordinate care and to integrate care and keep patients out of the hospital and, attack the, the social determinants of healthcare, maybe even do some behavioral health, all these kinds of things. And then I got to thinking, well, what kind of a workforce would that entail? And one of the things that struck me in your presentation is, the notion that when I think about adding another nurse, so I need to, figure out, well, what's the added outcomes or quality that I get from that decision, and how much will it cost me? And I get some sort of a ratio, some sort of a sense of that value. But if I'm that big ACO person, I'm thinking, well, okay, I'll do that with nurses, but I could also maybe achieve some of this if I hired a medical assistant, or maybe a licensed practical nurse, or maybe some of these things have to be done by a physician who has higher costs, or maybe a nurse practitioner. So my point is, in thinking about all this, isn't it the case that we really need to get sort of a value determination of all of the workforces, and then somehow come together and figure out, if I've got so much money to spend, how am I going to spend it among all these different people who have different sort of value equations? So I guess I'm asking you, does that make sense to you, what I just said? And if that does, what would you advise that ACO who's trying to make these decisions?
Yes, thanks. That's a great question, and it also gets at the individual productivity of different types of nurses, different types of clinicians, and so forth. And in the value equation, you want to match certain skills with certain outcomes. So part of it, taking a step back, is the ability of the individual to influence the outcome. So certainly a very basic outcome, say the front office staff and scheduling appointments, anybody could do that. However, it would not be a value-based decision if you had your most senior staff scheduling appointments. They do great. Presumably the outcomes would be fantastic, but the benefit of better scheduling is not worth the additional salary of having a highly trained person. And so being able to link the training of individual staff to their actual work is important. And there's also areas with scope of practice that has been in the news as of late, especially with nurses in some states. The ability of nurse practitioners to bill and see patients independently is restricted by state laws. In other states, it's relatively free. And so that's one example of a policy innovation that could include value if nurse practitioners were allowed to see patients directly, prescribe medications, and so forth. So it better match the skills and the training of the nurses to the task at hand. And there's ample scope in that area as well to improve value. And we'll see. I think the Federal Trade Commission has been in discussions about scope of practice law and whether they violate their rules and laws on competition. And there haven't been any challenges by the Federal Trade Commission that I'm aware of, but that's one policy area which may see some movement in the future where there is better access of nurse practitioners to see patients independently and to better utilize their skills and training.
Thanks, Rich.
Yeah.
All right, I think that's going to do it for our webinar today. Thank you so much, Rich, for a great presentation, and we ended up having a lot of great discussion afterwards, so that was wonderful. Thank you everyone in the audience for your attendance, and keep in mind that our next webinar in this themed series will be Tuesday, October 6th at 2 p.m. Eastern Standard Time, and Olga Yakusheva will be presenting, and she'll be building on the foundation we've laid today with Rich's presentation and talking a little bit more about policy implications. So we hope to see you there, and thank you for coming.
Yes, thank you, everybody. I appreciate it.
Thank you.